Methadone is one of the most complex medicines that we have because it interacts with almost every medicine one way or the other. Methadone is broken down by enzymes in our body. And so, in combination with medications, other medications may induce those enzymes, and when they induce those enzymes, what happens is it breaks methadone quicker, and that dose doesn't hold the patient very long. They're breaking through in the afternoon, in the evening, they're feeling bad the next morning when they come in. And so we have to look at the dosage, we have to increase the dose. Pregnancy is an inducer of those enzymes, so one of the things that happens when you're pregnant, you may have to divide the dosage out to get good coverage. The other thing that happens with certain medications is they're inhibitors. When it inhibits that medicine, methadone accumulates more. And you can overdose very easily just by having your normal dose of methadone, and then your family doctor tells you, hey, you seem a little sad, I'm going to put you on this antidepressant today. That may kill you. So methadone is a very complex drug. Now, the drugs that interact with the QT interval, about that thick in a book. And we've got a lot. So we look up the drugs, we try to look. That's why we're always asking the counselors and asking each other, did you check their medication list? Did you ask if there's any over-the-counter meds? Did you check if they're taking any vitamins or supplements? Did you check? Did you check? Did you check? That's why so many people, you don't see us hardly ever taking somebody from buprenorphine and putting them on methadone. You've seen us take a lot of people that started on methadone and switch them over because we have that safety window.
Dr. Kearney, why does some patients, like when they come in, they tell you that's what they want? Is there a reason they tell you that's what they want?
Yeah, because number one, remember the methadone came into play in the 1960s. So it's the one that's been around. Buprenorphine came into play in 2000. So it's the new kid on the block. You can get very high on methadone. It's a pure agonist. And that's what a lot of times people come in, and I would tell you, when they first come in, almost 95% of them, they're not looking for help. They're looking for a way to control the drug rather than the drug control them. They want to continue with the recreational use. They just don't want to pay the price and have to hunt it every day and go through the withdrawals and do all the things that it takes. They want to figure out a way that they can take the drug whenever they want to and it not make them sick and it not cost them all their money and not cost them their relationships. So a lot of times they're coming in with methadone because they've been on methadone before, and you get the full agonist effect. So you get that high feeling. Buprenorphine, we have a ceiling effect. So whereas methadone looks like this, so you're taking 10 milligrams, 20 milligrams, 30 milligrams, 40 milligrams, 100 milligrams. You know that taking 100 milligrams has 10 times the effect that the 10 milligrams did. And 20 milligrams is double, and 30 is 3 times. So you know it's a linear line until you reach respiratory depression and death. Okay? Now, when you compare that to buprenorphine, it does this. Okay? So, a typical dose, and here's respiratory depression here. So we have all this window of room on this drug that we don't have with methadone. When you take 8 milligrams, 8 milligrams, 16 milligrams, 24 milligrams. The area of the brain where the pleasure centers are, 8 milligrams, about 87% of the receptors are occupied. 16 milligrams, about 93%. 24, about 97%. So, 3 times the dose is a 10% change. It's on a curve. And it's not a linear deal.